for this kind of introduction. So now it's the liver. So my purpose will be to do an overview of what can be done in liver with shear wave elastography using supersonic imaging system, and what is known for now, what is the best way to use it in the most reliable manner, and also a word about the future during the conclusion, maybe what kind of application we could develop. So there is a long history between hepatologist, liver fibrosis, and Fibrous Scan. And as you saw in the first presentation, Fibrous Scan is a transient elastography system based on an external mechanical push. So it does not provide any image, but it's just a piston. And it's well known by hepatologists, but less by radiologists, because it does not provide any image. But now we have in our hands, us radiologists and also hepatologists, tools that seem to be more powerful because it allows us to do a real-time 2D elasticity map of the liver where we want in the liver, almost where we want in the liver. And we are no longer limited by the ascites, for example. So it seems to be very interesting. But in order to use shear wave elastography with a supersonic imaging system, we need to answer all the questions that were already answered by transient elastography in the past. Does liver stiffness using supersonic imaging system correlate with the degree of fibrosis, at least as well as transient elastography, which is well validated by a lot of studies in the past, or even better? Does liver stiffness correlate indirectly with a complication of cirrhosis, like portal hypertension, for example? Is it reliable? Is it reproducible? How is it compared to transient elastography? And what about the use of 2D shear wave elastography with tumor in the liver? So let's start first by the first question. And the first question is, does liver stiffness using supersonic imaging correlate with the degree of fibrosis? So unfortunately, the answer is yes. There is now a lot of studies using supersonic imaging system that have shown that it was possible to assess the liver fibrosis with proof with a reference standard, that is the liver biopsy, or the comparison with transient elastography. And I just want to show you recently, in 2016, 3 meta-analyses gathering the paper using real-time 2D shear wave elastography and using as reference standard the liver biopsy. And you can see in these 3 meta-analyses that the sensitivity and the specificity to diagnose F2 or significant fibrosis or cirrhosis are very high, and with a sensitivity above 44% for F2 and above 87% for F4, and with a specificity which is above 81% for F2 and 86% for F4. So very good sensitivity and specificity to diagnose F2 and F4 with real-time 2D shear wave elastography. Here are also some studies that compared transient elastography with shear wave elastography, not taking into account the etiologies of the chronic liver disease, but mixing them all together. And you can see in these 4 studies that shear wave elastography, which is this one, compared to transient elastography, did at least the same or even significantly better than transient elastography to identify stage greater than F2, greater than F3, or equal to F4, and it's the area under the ROC curve, so the accuracy of the detection. So now evidence are enough, I think, to say that equivalent or sometimes superiority in diagnostic accuracy is found for real-time 2D shear wave elastography versus compared to transient elastography for the diagnosis of significant fibrosis, F2, advanced fibrosis, F3, or liver cirrhosis, F4. But we all know that the different mechanisms that lead to damage, to the liver damage, are very different according to the underlying liver disease, to the cause of the chronic liver disease. So it means that the cutoff values to evaluate the presence and severity of liver fibrosis may depend on the etiology of the underlying liver disease. And not only the etiology of the underlying liver disease, but also the different elastography technique we used. So it means that for 2D real-time shear wave elastography assessed with supersonic imaging system, we need to do exactly the same path that transient elastography did in the past. We need to validate the cutoff values to assess the liver fibrosis for each cause of chronic liver disease. And it's not possible to just transpose the cutoff values already identified with transient elastography towards supersonic imaging, because it's not the same technology and the result will be different. So this work is currently being done and has been done in the past year and is still actually being done. And we compare the performance of shear wave elastography to transient elastography for each cause of chronic liver disease. Here, it's two papers focusing on Hep B virus, where you can see again, with area under the arrow C curve, that the accuracy to diagnose fibrosis greater than F2, F3, or F4 are always a little bit better with shear wave elastography, and even significantly better in some studies. Same thing for Hep C, where you see that shear wave elastography performs at least the same or sometimes significantly better than transient elastography. Same thing for NASH, with a limited number of studies and with an area under the curve which is a little bit lower, but again, shear wave elastography performs at least as well as transient elastography and sometimes significantly better. So it has been stated in the EFSUM guidelines that were published 8 months ago that in chronic viral hepatitis C and B, real-time 2D shear wave elastography or transient elastography could be used as the first-line assessment for the severity of the liver fibrosis. For alcoholic liver disease, it's a little bit more complicated because we know that transient elastography can only be used to exclude cirrhosis if confounding factor is not present. Here it's acute alcoholic hepatitis. And EFSUM guidelines stated that there is still insufficient evidence to evaluate the role of 2D shear wave elastography, but also point shear wave elastography in this case. But still studies are ongoing and we will know it soon. What about the cutoff values we can use? Of course, we need to know what is the normal range of healthy liver. So there is a lot of studies and they were gathered in the EFSUM guidelines, and here the results. And so you can see that 95% of the healthy liver have a liver stiffness smaller than 6.2 kilopascal with supersonic imaging and 6.7 kilopascal with transient elastography, with Fibrous Scan. Okay, now what about the cutoff values of the liver stiffness to assess the severity of fibrosis? From what we said previously, it is obvious that we need to calculate, to assess the cutoff value for each cause of chronic liver disease, not generally speaking, but for each cause because it may vary. So this is a table, these slides show the results published in the literature for each cause of chronic liver disease, Hep C, Hep B, NASH, and alcoholic steatohepatitis. So you can see that the threshold values to declare F2 is very similar for Hep C, Hep B, and NASH. It's around 7.2 kilopascal. But it's more heterogeneous for F3 and more heterogeneous for F4 depending on the cause of the liver disease. And for example, F4, it's from 10 to 16 kilopascal according to the underlying liver disease. So okay, we need to know what is the chronic liver disease, what kind of chronic liver disease we are dealing with to choose the correct threshold. But then us, radiologists, we are not always aware of what kind of liver disease it is, not because we are not informed or because the patient does not know because we are at the first line. So we sometimes do the examination for the first time and the patient doesn't know his pathology. So in this case, which line should we use? So in this case, the best thing is probably not to try to stage the fibrosis, but just to provide the raw data, the liver stiffness. And then another reason to do that is because we don't know the confounding factors that can be acute hepatitis, infiltrative hepatitis, chronic cholestasis, and so on, that will overestimate the fibrosis. So the best is probably to provide just the number, and we can use at least a very simple scale, which is this one. When we don't know the etiology and we know nothing about the confounding factors, then it is wise to say that below 5.4 kilopascal there is a minimal risk of fibrosis. Above 10 kilopascal there is a high risk of advanced fibrosis, and in between it's intermediate. Let's move toward now the complication of the cirrhosis, and particularly portal hypertension. There are a lot of papers published about this, and I would like to share with you 3 papers. This one was published in 2015, and Prokopet found that it was possible to use the liver stiffness as an indirect marker of the clinically significant portal hypertension. And with a setup, with a threshold of 17 kilopascal, then we can detect a portal hypertension with a sensitivity of 81% and a specificity of 82%. We can also have another strategy, which is to set up 2 different thresholds. One with a sensitivity greater than 90%, then to rule out portal hypertension, and then the threshold is 14 kilopascal. And one with a specificity greater than 90% to rule in portal hypertension, and then the threshold is 25.8 kilopascal. But there is not only the liver stiffness to assess the portal hypertension. It is also possible to assess the spleen stiffness, which is possible with a supersonic imaging system easily because it can be done on real time on B mode. So then, what is the added value of the spleen stiffness? This paper, published in 2015 in Radiology, found that if we set a threshold at 34.7 kilopascal, then we have of spleen stiffness, then we have a specificity to diagnose portal hypertension very high, but with a disappointing sensibility. So that's probably why Jensen, a year later, proposed to combine both measurements, liver stiffness and spleen stiffness, with this algorithm. So you first perform a liver stiffness assessment. If it's high, portal hypertension. If it's low, then do a measurement of the spleen stiffness. If it's high, portal hypertension. And if it's low, probably no portal hypertension. And doing this, these authors could reach a sensitivity above 98% to rule out portal hypertension, which is very impressive. What about reliability and reproducibility of real-time 2D shear wave elastography? Of course, reliability and reproducibility are governed by the quality of the acquisition. And of course, we need to do the measurement in an area where the signal is stable with time. Here, it's not obviously the case. In this patient constantly breathing, you can see that the signal is constantly changing. So it's obvious to realize that in this case, the measurement won't be trustable. And it's made very easy by the fact that it's real-time acquisition. And so you can realize easily that this one will not be efficient. But in addition, the vendors added an additional index, the temporal stability index, which is IS, which help us to find the area of measurement which is the more stable. In these two ROI, you can see that one is with a stability of 84% and one with a stability of 99%. So this one is probably more trustable than this one. So these values is probably most trustable than this one. So an arbitrary threshold above 90% is considered as enough to allow a correct measurement of the liver stiffness. Of course, then, to be reproducible, there is a lot of guidelines that were published by the FSUM last year, and they are very important. It's like the learning curve for the breast. We need to follow these guidelines to be the most reproducible possible. And for example, a patient should fast for more than 2 hours and rest for a minimum of 10 minutes before the measurement. Measurements of the liver stiffness should be performed through a right intercostal space in supine position with the right arm in extension during a breath hold, avoiding a deep inspiration. Otherwise, you can do a Valsalva maneuver that will increase artificially the liver stiffness. The measurement of the left lobe should be avoided. The measurement should be performed between 4 and 5 centimeters in depth because it's the position where it's the more reproducible. The minimum of 3 measurements should be obtained instead of 10. I remind you that for transient elastography it's 10 measurements. And doing that, what is the technical success rate of the measurement of the liver stiffness using supersonic imaging? Is very high. It's, according to the literature, it's above, for the minimum, it's 87%. Otherwise, it's mostly above 90%. And what about the reproducibility? Again, in the literature, the intra-operator agreement is very high with an intra-class correlation coefficient above 90% in the literature. And the inter-observer is also very high, above 83%, which is very, very high, so very reproducible. So, and finally about the confounding factors, they are very important. And in the FSUM guidelines, it is said that liver inflammation, obstructive cholestasis, liver congestion, acute hepatitis, infiltrative liver disease may completely modify the liver stiffness and should be excluded before performing the liver stiffness measurement. Of course, if it's not possible, then it must be considered before interpreting the shear wave elastography results. That's again an argument to say that when we don't know all these things, the best way is to provide only the number of the liver stiffness results and not try to convert it into a stage of fibrosis, because then we need everything like that to be able to do it. What about focal liver lesions now? Of course, shear wave elastography with 2D elasticity map and real time allows us to do something which is impossible with transient elastography, to study a given part of the liver and why not a liver tumor. And it has been shown that the malignant tumors are a little bit stiffer than the benign lesions, except the focal nodular hyperplasia. And FNH is much more stiffer than the other benign lesion, and particularly compared to hepatocellular adenoma. So this technique could be a helpful tool to help us to distinguish between FNH and adenoma. And even more interestingly, Maxime Renaud in 2015 found, again, that FNH was stiffer than adenoma, but that we could distinguish between telangiectasic adenoma and steatotic adenoma because they have different stiffness. So there is probably a new tool to add to the other one, like contrast-enhanced ultrasound, like Doppler and so on, to have an opinion about the focal liver lesions. So to conclude, I would like to say that, first of all, real-time 2D shear wave elastography is actually taking the same long validation path that transient elastography did in the past. But I'm sure and no doubt that it will succeed and that it will go further, because already the paper already published found that the results were similar or often significantly better than for transient elastography. Then it could be the new reference. And we are just at the beginning of the story for the technical point of view we discussed before, and also maybe because now this technique is within the ultrasound machine we as radiologists have. So we are in front line, we are in first line in front of the general population. Transient elastography is well validated. It can be done by a nurse, but it's accessible only through an hepatologist, not in front line, not in the first line in front of the general population. And we know that there is a lot of potential patient in the general population that have a chronic liver disease, and particularly an hepatitis C, and they don't know they have it. So maybe it would be very interesting to try to know if using this kind of technology in first line, us doing general abdominal ultrasound, would help to detect all these patients. And there is actually a research ongoing in France, and the purpose is to perform a large screening with shear wave elastography during a B-mode examination of any kind of patient, not the one known with liver fibrosis, but any kind of patient, to know if we are able to detect and to refer to a pathologist patients who don't know that they have a chronic liver disease. So this is an interesting public health consequence of this kind of tools when they are implanted in first line in the ultrasound device. Thank you. Thank you very much.